All right, good evening. I'm going to go over really quickly the new postpartum hemorrhage care redesign project. This is a project that was initiated by Adventist Health to deal with the issues around postpartum hemorrhage. Through it, we created a new protocol and procedure and policy, which included power plans and new nursing and physician documentation. This was performed and developed by our local team, Catherine Cisco, Katie Cisco, Virginia Medina, Krista Minton, and myself, along with the clinical informatics team at Adventist Health. All right, so what is this care redesign project? Basically, this is aligning to policies that and toolkits that were available through CMQCC, California Maternal Quality Care Collaborative, developed to more readily treat postpartum hemorrhage and deal with a significant maternal morbidity, mortality related to postpartum hemorrhage. This toolkit has been around since 2010, and it's evidence-based and has been shown to decrease morbidity, mortality related to postpartum hemorrhage. One of the reasons we're doing this care redesign project is that Joint Commission is requiring by January 1st, 2021 that every hospital has a stage-based protocol for postpartum hemorrhage. And the policy that was developed aligns with the Joint Commission recommendations, also requirements, and also CMQCC and ACOG guidelines. All right, so I'm going to just touch briefly on the workflow changes that are going to be specific to physicians. So I won't go through the entire changes in the policy. I'll touch on the main things that will affect the physicians and their day-to-day workflow. Just one of the quick brief overviews. The policy was sent out through email since we're not having department meetings, so it is there in your inbox to be voted on. If you haven't voted on it already, look it up and vote on it, read it through. More information is there. Also, specifically in this protocol, we are going to be quantifying blood loss, not estimating blood loss, but quantifying blood loss. The other significant change in this protocol is that stage 1 interventions will be nurse-driven, and I'll explain that more. Power plans are created for each stage in postpartum hemorrhage, and there are changes in some documentation to help providers document these episodes. All right, so the first thing I want to touch on is the postpartum hemorrhage risk assessment. When every patient gets admitted, the nurse will go through their history, and through the EHR, they're going to be able to stratify their risk assessment into low, medium, and or high risk based on their diagnoses and history. You'll see there the categories which make patient low risk, medium risk, or high risk. Once that's decided and documented, depending on which risk category they're in, it will trigger different orders. In a low risk, we'll simply get a type and screen. If you are high risk, patient will be automatically typed and crossed for 2 units. The provider will automatically be notified that the patient is high risk for postpartum hemorrhage. They may place a large bore IV and notify staff appropriately. This risk assessment will be ongoing in that once patients admitted to labor and delivery, the initial assessment is done, but as they go throughout the process of the entire admission, that risk assessment may change, say if patient has, for example, chorioamnionitis or other issues that may increase the risk for postpartum hemorrhage, and that will be changed as their care goes through their entire admission. All right, this is postpartum hemorrhage identification, and treatment. So this is the big thing with this, is that the treatment of stage 1 postpartum hemorrhage is going to be a nurse-driven protocol. What that means is, on every patient that's admitted, there's going to be a nursing communication embedded in the admission orders that will state that when the patient has an EBL or QBL greater than 500 mLs, the nurses can go ahead and initiate the stage 1 protocol. Okay, on the slide, there's an example of things to do. The first thing they're going to do is they're going to notify the provider. Then they will bring the hemorrhage cart into the bedside, vigorous funnel massage, etc., as we see listed there. In addition to that, they will be able to give Pitocin, oxytocin, at the rate recommended per CMQCC, and also ACOG, and also be able to give Methergin per protocol. This is an example that you see here of a regular admission order set. As you can see, highlighted in blue is the communication element here in the order set that says activate stage 1 postpartum hemorrhage power plan per protocol, for greater than 500 mLs of bleeding from vaginal birth, or 1,000 in the cesarean section. When you open up that power plan, this is pretty much what it says. You'll see at the very top of the list on the order set, it says notify provider, which is the first thing they'll do. In addition to that, they will do vital signs, oxygen therapy, so on and so forth. As you see highlighted or circled is the medications to give oxytocin and Methergin as needed. All right, so they'll be able to quickly initiate that therapy while provider is being notified. The difference between the stage 1 and stage 2 protocol, but that the stage 2 protocol is provider driven, meaning that when you are at bedside and the bleeding is persistent despite the initial therapy and is less than 1,500 mLs, that meets stage 2 protocol. And you'll be able to just say to the nurse, or either manually enter or say to the nursing staff, please activate stage 2 postpartum hemorrhage protocol, and all of these things will take effect. It lists all the medications that can be given, Methergin, Hemabate, misoprostol, sublingually, tranexamic acid. Those are all going to be pre-checked as PRN. In addition to that, it has all the stat labs, CBC, coags, CMP, fibrinogen. So stage 2 and stage 3 protocols are not nurse-driven, but provider-driven. So these are the other things you'll see in the stage 2 protocol. They will activate rapid response overhead. They'll activate those teams. They will also assign different roles to the team members, such as someone to communicate or retrieve blood, administer medications, or record. Also bring the crash cart into the room, so on and so forth. Document vital signs, start a second line, warming blankets, bimanual uterine massage. Also, Bakri balloons are going to be available, as you know, in the hemorrhage carts, and this provides orders for that as well in the stage 2 protocol. Also, moving patients to the appropriate level of care. Patients in postpartum, there are orders to move the patients to L&D or L&D OR. Also, orders to provide communication to family during this emergency. Okay. This example, what the stage 2 protocol looks like, which we kind of looked at already. This is example. This is not as detailed, the stage 3 protocol. At this time, you're probably rushing to the operating room, if not in the operating room. This may be a time that you initiate the massive transfusion protocol. That'll be a separate power plan that's also being developed in a care redesign initiated at Adventist Health Rideout. All right, so those are the power plans. Again, stage 1 is nurse-driven. Second thing that's... Okay, so those are the power plans, and again, for stage 1, that will be nurse-driven. All right, the second thing I want to go over are the EHR changes. Again, to summarize, there's going to be an initial risk stratification that the nurse will do that flows through our EHR. Also, there's been entire iView documentation for nurses that's been developed and a significant workflow change for them in documenting postpartum hemorrhage. They're going to be trained over this over the next few weeks. Also, patient education that is required through joint commissions. This will all be available in the EHR. The thing that I want to bring up for physicians is the creation of a dot phrase for postpartum hemorrhage. You may use dot phrases already in your documentation, specifically for dot vital signs or dot labs. This is going to be dot PP hemorrhage. In your dictation or documentation, if you just type dot PP hemorrhage, this will come up. It is going to it's going to show you all the medications that were given in stage 1 and during stage 2. It's going to pre-populate all of the QBL, EBL, and cumulative blood loss that's been documented through the iView that the nurses do. And also it'll list vital signs, so you can include this when you're documenting a postpartum hemorrhage. To go into more definition about the QBL, EBL, and cumulative blood loss. The cumulative blood loss is the blood loss that's going to be added up through the EHR throughout the course of the admission. Say if someone has a postpartum hemorrhage on labor and delivery, then has bleeding later on in postpartum, it's going to calculate all of that cumulatively and give you cumulative blood loss for the whole admission. We'll talk about the quantitative blood loss. The EBL, or estimated blood loss in this context, is there to describe blood losses unable to be quantified. Say if there's blood on the floor or blood on the toilet, they will estimate that and put it in specifically as a estimated blood loss. And we're going to talk about the QBL. So anyway, that's the dot phrase. Remember, dot PP hemorrhage. QBL, you will see this on the policy. If you open up the policy that was sent out, it talks about every delivery, cesarean or vaginal, we will obtain a quantitative blood loss. Because basically this is going to drive our protocol. All right, so QBL. How do we get it? How do we measure it? Well, vaginal delivery is there on the right. We're going to use the under buttock drape. My personal tip is to, when you deliver the baby, put the baby on mom's belly and start the clock for the 60 seconds delayed cord clamping. Take a second, look at the bag, measure the amniotic fluid. Call it out to the nurse or keep it in mind. At the end of the procedure, now look at your total fluid in the bag minus the amniotic fluid, and that's your QBL. Pretty easy. In terms of cesarean section, a little bit more goes to it, but it's the same idea. As soon as baby delivers, try to quantify the amniotic fluid. As baby is there for delayed cord clamping, take that 60 seconds and either try to estimate or suction all of the fluid and get a number that you can use for a QBL calculation. To discuss this further, the QBL in the cesarean section, this is the simple formula. QBL, this is the bottom line, equals total fluid collected volume, subtract the amniotic fluid, subtract the irrigation. How do you get the total fluid collected? Well, you look at the suction canister and see what it's at. Say if it's 1,500 in the suction canister, then you add the volume from the sponges, the sponge fluid volume. The nurse concurrently will be quantifying the amount of fluid that is in the sponges, then measuring and calculating what the fluid in the sponges are. So you add those two together, the canister and the sponge fluid, and you'll get the total fluid collected. So let's say that's a total of 2,000. You subtract the amniotic fluid, which is say 200, and you subtract the irrigation fluid, and then you have your QBL. And that's how that's done. QBL and an NSVD we talked about already. Okay, lastly is I want to talk about the debrief portion. This is part of our policy that we will do a debrief on these cases. The debrief will be multidisciplinary with nurses, RT, anesthesia. An occurrence report will be generated, and this is on the left is what the perinatal debrief form is going to look like. So it's a chance for us to get together. It's better if this happens immediately after the event, to go over what went well, what didn't go well, what could be faster, what were the barriers. This will help us keep track of these things, to keep track of issues, and also to help improve our process to make it more responsive for our patients. So that is it. That's all I want to share for now. I will attach through email the entire detailed PowerPoint presentation. A lot of it is what the nursing process is. If you want to look into that, that'll be there for you. Again, look for the policy in the email. There's much more detail there, but I just wanted to share some of the workflow changes that are going to arise when September 1st rolls around. And that is it. Hopefully this is successful, and we'll be able to implement this throughout the system of Adventist Health. I want to thank from the bottom of my heart all the work in this project done by Katie Cisco, Virginia Medina, and Krista Minton, as well as the clinical informatics team at Adventist Health. That's all. Have a great evening.